It's like my favorite thing. All right, we're ready. And here we go. The, that famous chart that you'll need to know is on the Nestor PowerPoint, which I uploaded. We're not getting to that till sometime next week. So let's just, this is more about both these start. And actually, I like aspects of this even better, but there's some things that are more thorough on the other one. It's the old story. So there's a lot of definitions in this chapter: sterilization, disinfection, antisepsis, things like decontamination and sanitization, degermation, which I don't even think is a word, are not words you have to worry about. I'll give you the lowdown on why certain words are used. We're looking for different measures. You can see there's two categories: physical and chemical, effectively. Those are the two significant categories when we're talking about methods of control. Again, this has nothing to do with antibiotics or what we call antimicrobials. That's a different group of information. That's a different area of information for all of our purposes. And that's a separate it's actually the next chapter in the text, but we don't do it right away. And so and we'll talk about the targets and things. And the targets are pretty straightforward. We look at the cell wall. We look at peptidoglycan. We look at membranes. We look at ribosomes. All sorts of things that you look at. We look at genetic material, that kind of stuff. So all of this is important because we've learned about the different ones, and frankly, most of them don't harm us. To be very clear, viruses are separate. Viruses are foreign to us, but most of the bacteria are our friends. So we got to find a way to control these without clobbering the ones that are our benefit, like all the ones on our skin, for instance. So this is just the designed to result in 4 possible outcomes. I'll buy this. Sterilization, that's more apropos of people in clinical or medical careers, nursing careers, any health-related career. You have to understand what sterilization is. Sterilization is a misunderstood term in the sense that things are only sterile once they're open, they immediately start to become non-sterile. So if you're walking into an operating room and someone opens up a sterile pack and puts it on a sterile, quote-unquote, sterile table or a sterile field, all terms you'll learn about, it immediately starts to pick up microorganisms. It's a matter of time, to be very honest with you. Once things are open and exposed, effectively within an hour, they are no longer sterile. That's why you laid down the road. We start talking about this a little bit, sort of generically, about how we guard against things like this. You're going to see a lot of things what we call double wrap sterile. So you'll pop open you flip open a sterile package, and inside it's still sterile. So it's like a double wrap. So you open it up. Now it's sitting on a sterile field, still unwrapped and sterile inside. If you don't use it, it makes it very easy to reuse it without having to go through all the re-sterilization. You'll see a lot of those kinds of things when you get into a hospital, many of you, and you start getting oriented toward an operating room. It's a very interesting place. You're going to hear terms like, we're going to apply sterile dressing. If you want to be a purist, there is none. It's varying degrees of asepsis is a better word to describe it. I will give you this advice now. If one of your nursing instructors, for you, those in nursing, says we're doing sterile dressing changes, do not go, Dr. Stein says they're really not sterile. Just, yeah, oh, great. Can't wait. Tell me all about it. Got the idea? It's enough that you know and I know, we know, our little secret. So we'll talk about disinfection is what you routinely do, what many of you yesterday in lab did not do as you were instructed to do. Cleaning off the tables. Going in and going out. You probably did because you're diligent. Some of you, you're lucky you're at the right table. Okay. So stop. Nobody likes you anymore. So that's basically disinfection. That's about inanimate objects. These are governmental terms. Decontamination, sanitization, and whatever the hell degermation is. D-germ is over there on D table, clean a D up. That's all I can think of with this. It's stupidity. Okay, Again, who determines what's sanitized? Who determines degrees of contamination? They are governing bodies. So whether it's federal, state, local, the hospital that you're working out, the government agency you're working out, the research lab you're working out, whatever, that's different. So those are, the standards are different as something that would be considered decontaminated if you're working in an operating room or you're working in a field hospital someplace, working with Doctors Without Borders or something, or on a medical mission. I mean, you kind of look at what the surroundings are and you get an idea how we can make this as sterile, quote unquote, as possible. Antisepsis, which is, I have no idea why they use that term, idiocy. Antisepsis is designed for living things, is basically to reduce the degree of microorganisms on living tissue. Washing your hands. Okay, for instance, that thing over there by the door, the whole hand sanitizer thing. Those are all, by definition, antiseptics. They're designed to be used on skin, where disinfectants are designed to be used on inanimate objects, whether it's a table, whether it's a consumable. We'll talk about it, pasteurization. And almost all your consumables, if required, are pasteurized, are all basically that as a form of disinfection. Except we're not using a chemical disinfectant. So, voila. So, the term sterile should be used only in the strictest sense. I agree with that. There's no, it's like, I hate the joke, it's like being a little bit pregnant. Very specific as to what it is. Slightly sterile, okay. Inanimate, not generally, it is reserved for inanimate objects, okay. And surgical instruments, syringes. Food is interesting. I don't know if I'd include that in there when they talk about commercial sterilization. It's not the same as sterilization for an instrument in the operating room. The standard is slightly lower. In commercial sterilization, you're worried about a particular endospore, botulism. In an operating room sense, you want all endospores destroyed. So it's a subtle difference. And by definition, the process destroys or removes all viable microorganisms, including viruses, and what it should be, including endospores, including bacterial endospores is the appropriate definition. No other definition suffice. The last topic we engaged in here on Wednesday was prions. They're not in the discussion. And you could open a sterile package and theoretically it could be teeming with prions. I would not go home and fret over this all night long. The reason it is not included is we do not know. And unless we know what controls prions, you can't presume. We have some ideas what, at least from a technical sense or an experimental sense, would control them. But understand, when you open a Band-Aid that says contents guaranteed sterile until open, prions are not part of the definition. So definitions are important. Okay, to understand that even they have limitations. But this should be remove all viable microorganisms, including not viruses, bacterial endospores. Bacterial endospores are the hardest. Viruses are down in the pecking order a little. And I'm sure I'll find a slide, maybe on the other PowerPoint. So what do we use? We use typically heat. We use different types of chemical agents that are capable of destroying endospores. By definition, we call them sterilants. What would be an example? Bleach. More about that down the road. Disinfection. Chemical agent destroys, and a physical process like heat, chemical agent to destroy vegetative pathogens, but not endospores. So it's not as strong. Removes harmful products of microorganisms from material. So bleach is part of that. Typically, different concentrations of bleach and different amounts of time will allow bleach to be used as a sterilant. Iodine, which is probably mislabeled here, because iodine to me is more of an antiseptic. And the most famous one of them all, and boiling is one of them, but the most common form of disinfection for a consumable, and I mentioned it before, is this guy, pasteurization. And that was, remember when we talked about that early on with the historical figures? He was all about trying to get things, spoilage organisms out of the wine. And he came up roughly with a temperature of 62.5 degrees Celsius. It's about 140 degrees Fahrenheit. And for 30 minutes, he was able to basically clobber all the spoilage organisms. That's the classic example. We'll get to some other numbers that are associated with more modern day pasteurization. Okay. You know, what we refer to it now is called the batch method, and it's still used. Most of you are using it at home. Batch method, METHOD. Done him. That wonderful thing that I assume you don't have them in dorm rooms. Who knows? But maybe there's a common one. Like, is there a common kitchen anywhere? No, probably. Okay. Do they have a dishwasher? Okay. Your dishwasher. Okay. The cycle in the dishwashers roughly hold a temperature of 140 degrees Fahrenheit for 30 minutes. So effectively, when you put your dishes into the dishwasher, you are pasteurizing them. So you will not have, nasty kinds of toxic E. coli sitting on them. Basically, that's it. So that's where you can cook in one of those because it holds the temperature 140 degrees. I mean, there's neat recipes where you can see it. It's called sous vide. No. Sous vide is where they have these. You seal packages and you can put like different flavor components and you sort of vacuum seal them and you put them in a controlled temperature environment and let them sit there. And people have these systems at home. So they can, if they both work, they can come home and be on a timer, and it'll be ready. Okay. Look it up. Don't watch enough cooking shows. So, normally used, not normally, it is used on inanimate objects because it would hurt the skin. Basically, nobody's washing their hands with bleach. So, you could boil food utensils, just as easy to pasteurize them. Bleach solution. You're going to see when we get to it, the bleach that we use is diluted. Okay? You've got to be careful with regard to bleach. When bleach is an effective sterilant, it has to be on there. Chemicals have to be on there for a long amount of time. Probably a minimum of 3 hours, sometimes as much as 12. So go sterilize that table. Here's the bleach. Again, if it's one of your instructors, go, I'm on it. Rather than Dr. Stein says it only works if it's on here for 3 hours. And it's true, it only works if it's on here for 3 hours. But again, if you know and I know, that's good enough for me. Sanitization, again, to safe levels. It's an arbitrary figure. Who determined it was safe? Maybe the FDA, maybe the county. When you hear about a restaurant being cited for problems, okay, or a dairy or a brewery or other commercial facility, they're being inspected. Okay, and so the idea of that is it's an entirely different standard that is not universally. It'll be different in this country than in another country. It might be different in California than it is in Pennsylvania, etc. Think about some place that might have stricter rules than we would have. Okay, so all of that, we'll look at that. And then antiseptics, okay, reduce the number on skin or living tissue. It is a form of decontamination, but on living tissue only. And so we're limited. And I would have taken iodine and stuck it right in there because that's really where it's more appropriate. Okay, hand scrubs will go into all these chemicals. A lot of it involves mechanical activity. There's some overlap. So these are just some of the definitions to start. I love this table. That's the best thing about one of the better graphics that you can see. You look what yields sterilization. What predominates? Heat, physical agents, including radiation. Chemical agents, somewhat limited. Gases will go into it. On inanimate objects, we can go into it. Mechanical removal and sterilization is very specific. You have to know what the organism is. When you hear about something that's cold filtered, okay, cold filtered, if for instance, a la Pasteur, the contaminating agents were we eat certain microorganisms. He could filter them out. So when you hear about cold filter, particularly with regard to beer and other types of beverage consumables, they can do that with things that the heat could damage them. It's very limited. What they don't include here in mechanical removal is the single most important one that you and I do all the time, washing our hands. We do a lab, hopefully we'll certainly do it in my lab, a hand sanitizing lab. And we're going to explore it with no soap, with just plain water, without soap, with bar soap, with antibacterial soap, with specialized soap. Okay, we're going to do all of those things. We're going to use Biol, a waterless system, and you're going to see the results are very, very, very similar. Just to give you an idea, there's no real dramatic statistical difference. What's the underlying factor? It's mechanical. They'll tell you this in nursing and in other clinical fields. How long should you be washing your hands? Roughly 30 seconds. Vigorously. There's good news and bad news with that. People who are overly reliant, and I do that as a joke when we start the class. It's like they see one of those things. Maybe go do it obtrusively. You walk around very proud of yourself. Everybody will admire me. I'm sanitizing my hands. Oh, that's not true. You know perfectly well you see people who are doing it. They can't go buy one without touching it. Oh my God. Germaphobes. The reality is your skin is your greatest barrier to disease. That dries your skin out. So if you're going to be a hand sanitizer, that's okay. I can deal with your obsessive compulsive tendencies. It's good news. There are moisturizers. Use them. Men, women, anybody. Whatever you want to be. Make sure you use it because your skin is your best friend when it comes to potential sources of systemic disease. So it's just great. We're going to deal first with physical agents, particularly heat. Why heat? What makes heat so good? This is one of the units I decided not to test you on in the interest of time and because I had to be away and, it's not something what makes heat. The living systems, when we talk about things that impact living systems, we go back to this. Part of my bad one. That is a bell curve, right? Normal distribution. Yeah, I'll see it. I mean, theoretically, if this was the average temp, this would be optimal temp, meaning the best temp to live in. And when we got colder or when we got hotter, growth would drop. Not true. That is true for pH. It is not true for temperature. Living things don't behave that way with temperature. Turn on the light, you have to go with it. The temperature curve is like this. It looks like a bell curve, and then boom! Long cliff. What happens is the optimal temperature, we call T optimal, is very close to T lethal. Think of it. Our optimal temperature for growth is 37 degrees Celsius. You get to 42, 5 more degrees Celsius, you're good. That would be 107.6. I don't know of anybody who has survived a temperature of 107.6. They're going to die. 41, 105.8. Doesn't look good. Anything over, once you get 107, once you get close to 108, it's very unlikely you're going to survive. Do you understand what I'm saying here? The optimal temperature and the least, that's what's the beauty of temperature. Okay? We can assure when we kill things, okay, we're not killing them, we're just suspending their growth. When we heat things sufficiently under the right circumstances, we clobber them. Dead. Sleeping with the fishes. More. 6 feet under. Taking the dirt. Sorry. That's another word. That dirt nap thing is one of my favorite offbeat movies. Christopher Walken, called The Prophecy. Very strange. Which is why it was perfect for Christopher Walken. Not in your purview, that movie. Never going to win an Academy Award. But it's the first time we really paid attention to one of my wife's favorite actors, Viggo Mortensen. That's the only reason I got her to watch Lord of the Rings. He's really good looking. Yeah. See, then I'll watch it. Terrible woman. So disinfection, destruction, removal of vegetative pathogens, but not endospores, not usually, but only inanimate objects. Sterilization, all viable microorganisms, inanimate objects, living things. You can't sterilize skin, it's living. Bacteria, endospores, antisepsis, chemicals applied to body surfaces, and who cares? Okay, so capable of causing infection or spoilage in the environment or on the human body. And there's lots of different ones, and there's a whole lot of variations. Bacteria and endospores traditionally have been considered, this is true. The goal is the destruction of the endospores, this is true. If it kills the endospores, it will invariably kill, whether it's waxy capsules like you did with acid fast staining on Mycobacterium, get it? Something called protozoan cysts. Those are the kind of things we see in contaminated water, like with septic tanks and that type of thing. They're very hard to destroy. Cysts are a form where these organisms that are like us, eukaryotic cells, kind of go into a state of suspended animation. Naked viruses, we talked about that, like with norovirus. Every day I see a new article about norovirus. If you look around and you can find that. I mean, another one, but there's been 3 outbreaks on one particular cruise line this year already, and it's only 2 months into the year. I mean, right now, I would not be taking a cruise, would not be high on my list right now. Just would not. I would be really, I mean, first of all, it looks like just a floating amusement park as far as I can tell. But I digress. Okay, so that's part of it. So here, again, prions, we don't know. We think they're the most resistant. When we see heat, we'll talk about it. Bacterial endospores. Look, tuberculosis and Hansen's disease, which happens to be leprosy. Next, Staphylococcus, a very hardy, and Pseudomonas, same deal. Very, very resistant bacteria. One's gram-positive and one's gram-negative, but they happen to survive very well. Here are those protozoan cysts. When they're not in the cyst form, they're called trophozoites. That's the active and spreading form. We will get to that. Okay, when we talk more about the individual diseases that are there. Gram-negatives, fungi, naked viruses. And now, gram-positive bacteria and enveloped viruses, relatively easy to get rid of. That's about the only thing. The enveloped virus is pretty much the only thing that alcohol wipe I talked about that you do on the skin gets rid of some surface debris, some dirt, okay, and some enveloped viruses. And it lasts for about 15 seconds, so you better get ready to inject fast. Another useful chart. Moist heat. 120 degrees, I'll tell you the actual number for endospores. Only 80 degrees. Remember we did that water bath experiment? Why that is somewhat inaccurate. You probably should crank it up another 5 degrees because there's enough variation. So most of you did not see, did you look at the results? I know my lab did. Most of the time at that 80-degree level, it wasn't getting rid of growth. It should have. We should have seen less. It's still very, very cloudy for most of your tubes, correct? It was certainly for yours and most of the groups. It should have done better. It didn't. Because 80 degrees is 176 degrees Fahrenheit. 20 minutes of that should have been sufficient. That's why I think those water baths they're useful, but I would crank it up an extra 5 degrees. That's me. Okay, So you're only looking at a 1.5 to, it's easy. I'll get into why moist teeth are so good. Radiation 4 times. Radiation is used a lot. You may be surprised, and people are very reluctant to, you don't publicize using radiation for methods of control because people think, oh my God, if I touch this, I'm going to start to glow inside. It's the stupidest thing you've ever, it dissipates very quickly. Go in the lab. Have you had to replace with dissection some of the blades on your scalpels up in the lab? No. Did Dr. Robbins replace any of them? Probably. What?
They need replaced.
What? Well, put new blades on.
We replaced them at the end of last semester.
I replace them every time we cut. The minute you get fat on them, they don't. Let me. Did I mention I did surgery for 25 years? They don't. Look at the little foil pack. You should not be doing it because it's the old story. If you cut yourself, it's a problem. If the instructor cuts themselves, it's annoying, but it's not a big problem. Your safety is more important than my safety as the instructor. To me, and it should be to any instructor. You're the first priority. It's honest to goodness. Don't have to thank me. I do this for a living. If you look at the blade, I should remind me, I'll go get one for Monday. It'll say sterilized by gamma rays. Every blade that you use in an operating room, you change them constantly. Every surgeon will want 2 or 3 blades ready. You're changing them all the time. I need a new blade. Oh, here's your new blade. Bang, bang, bang. You're cutting into tissue with fatty yuck on it. It dulls the blade. Nothing worse than it. So you basically, and they're all sterilized by gamma rays. Nobody's worried, oh my God, I'm going to start to glow. The next time I go into a room, it's going to set off x-ray machines and monitors. It doesn't happen. So we do it with a lot of foodstuffs. It would surprise you how many things you have to look closely. A lot of people don't like to see that, and they're reluctant because they think, oh my goodness, I'm exposing myself to radiation. Really, you're a whole lot more problem going out in the sun. Poison gas, the most commonly used agent other than moist heat. As you can see, you don't have to do, effectively what that chart tells you is you really, that it's a very usable agent. Okay, the next time you open up one of those sterile Q-tips, the next time you open up a syringe, okay, the next time you open up a Band-Aid, how are those all sterilized? Poison gas. We will get to it. Called ethylene oxide. We put them in a gas chamber. No two ways back. And this is something I use a lot. This is what happens, why it's a tincture of time. You have to have time available. 10 minutes be fine for just general disinfection. If you want to sterilize, a minimum of 3 hours, typically up to 12. Voila. More definitions, and these become important. Okay. Agent, we call them, if it destroys bacteria, bactericidal means to kill. Okay. And again, the implication is not in the endospore state. Fungicide kills fungi, spores, hyphae, yeast. Virucide, can't use the term kill because viruses aren't alive, so we say inactivate them, particularly on living tissue. This is the big player, sporicides. So things that have the capability of destroying bacterial endospores can be used as sterilant, period. And the generic term that we use are called germicides. You typically do a lab, hopefully you will do it, not only when you look at antibiotics, but you look at things like hydrogen peroxide, alcohol, things like that, that we commonly use, bleach, things we commonly use to deal with microorganisms. Then you dip a sterile paper disc in there and you put it on a plate with maybe some staph or some E. coli, and you see if it works or it doesn't. I get a little more exotic when I do the lab, that's me. I'm a little crazy about that stuff. And so when the term septic, it means there's something growing. And the whole idea, we're not really dealing with sterility, we're dealing with asepsis. Really, if you want to look back at Lister, he was the father of aseptic technique. The whole idea, and you'll hear me say this again and again, the whole idea of surgically, you're not sterilizing your hands when you do a surgical scrub and get ready to go into the operating room, which many of you will do and learn how to do. You're going to make your fingertips, the dirtiest part under your nails, clean enough so that you can basically touch the interior portion of a sterile glove and then immediately contaminate that, by the way, but the exterior portion of glove will be fine. And the same is true for your gown. The same is true for anything that you touch there and you already have on a cap and a mask and whatever eye protection it may or may not be required. That's the whole idea of how it works. In my lab, and you're all welcome to come. If you got nothing going on a Thursday morning when we're doing surgical scrubbing, I demo it. And I let you try it, the ones in my lab. So if you got nothing to do one Thursday morning at 11 o'clock, drop by. We're having a party. I actually have surgical scrub brushes. We actually impregnate them with iodine, with basically betadine soap, and with chlorhexidine, which we'll get to, which are the two agents that you use in the operating room. Like I said, I have clean hands. The pure heart, it's okay. So antiseptics directly expose wounds, skin and mucous membranes, surgical incisions, repairing the skin. We'll talk about that with iodine-based compounds, open root canal with hydrogen peroxide, ordinary hand washing. And it'd be nice to have a germicidal soap. It's not requisite to have a germicidal soap. Plain water works and good old soap and water works. I mean, do people still use bar soap? We still do. My wife likes a certain kind of bar soap in the shower. I use that. Yes.
Do microorganisms develop resistance to these things? Kind of like antibiotics?
Probably not. Basically, they're the ones that you're targeting on the skin. Basically, you're just trying to get rid of it. It's a numbers game. So they may or may not be resistant, but the combination of the agent and the mechanical activity gets rid of enough of them, they don't pose a problem. So, I mean, if you wanted to, from a lab perspective, you might see some resistance, to be fair. Short answer, don't know for sure. Okay. And these are two, when you see the term, and we're going to get to it with antibiotics, oh my goodness. The two most important terms are bacteriostatic and bactericidal. Okay. Chemical agents that prevent the growth of bacteria on tissues or on objects in the environment. We want things that kill them, not to slow the growth. Particularly when we start talking about antibiotics, it's not a good thing. That's why the three saddest words you can hear are allergic to penicillin, because it takes away most of your agents that are bactericidal. Cidal is better. Something is stopping the growth. Basically, you're stopping the growth and hoping the immune system will take care of it going forward. It's that old assume thing. You know what happens when you assume? I want to be dead sure. So fungistatic, same deal. Microbistatic, same deal. Okay. Cidal agents don't necessarily result in sterilization. Again, it's how it's used. Do we have enough time to use it, etc. So how we use them on different devices is also very important. Not everything has to be sterilized. By and large, this middle category is not as used as often today. So critical medical devices, sterile tissue. I mean, if you're going to be using it, what's sterile tissue? Anything. You have two barriers, your skin and the moist linings that start in your mouth and end on the exit point in your anus. The whole alimentary canal is basically a hollow tube that goes through, if you want to think of it anatomically. It's absolutely the way I teach it in A&P. It's absolutely correct. Okay, the linings, what we call mucosal membranes, are your protection. Theoretically, and for years, when someone would have a scope done, whether it was an endoscope or a colonoscope, okay, effectively, we used systems that did not sterilize them in between patients. Now we tend to do it more so than before because you're more worried about the risk of things like HIV or hepatitis C. Most of those systems, if you work in a GI lab, most of those systems are now what we call suitcase systems. They basically, after they've been used, you clean them off. You have a quote unquote suitcase, typically working with hydrogen peroxide, that will sterilize them in between patients. Years ago, they didn't. They would put them in a solution, okay, for roughly 40 minutes, basically the flip time between rooms. Typically, GI labs have 2 rooms that work. They'll use one and they'll have another one ready to go, but it'll take about 40-minute intervals. I mean, I just had an endoscopy done, and in September I had an endoscopy and a colonoscopy done over at North Hills Passivant. Those patients are flying in and out. They've got a couple of rooms working, and basically they're able to sterilize in between. Years ago, they would just put them in disinfectant solutions for 40 minutes. I think both the physicians and people in general were not as comfortable. What you had to sterilize were the ports where they could do sampling. And there actually was some problems with it here in Pittsburgh because the ports were not being sterilized properly. The only way they'll guarantee sterility of those ports is you must use the system that's purchased with the manufacturer. There's a lot of business type stuff that's associated with it. And I had a gal when I was adjuncting at CCAC who worked in the GI lab in a big hospital. And, they were made aware of where the problem was at another hospital. So, I mean, to me, it's anecdotal. I mean, I have no idea specifically, but they did have a couple of people who were inadvertently exposed to HIV. Not good. So nowadays, I think they're more common. So the assumption is everything is critical, and we sterilize as much as possible. I mean, you just sigh of relief. Whereas non-critical devices are designed for skin. Think of it. Stethoscopes, blood pressure cuffs, that kind of thing. Everything else, more or less, you're going to find is critical. So I don't see we use the semi-critical quite as much as they did years ago. But there are some, I'm sure there are instances where it is like that. Theoretically, that endoscopy they did, which went in my mouth, in my esophagus, in my stomach, and all the way down to my duodenum, could have just been high-level disinfected. I didn't bother to ask. Certainly have had no problems. So it's tough to find ways to sterilize. The trouble is, some things are hard to sterilize. Okay, they're not all created equal. Some of them are heat sensitive. Some of them are moisture sensitive. We have to find different ways. You don't have to really know about them at this point in time. So there's a lot of problems. There's no universal method. And really, when we think about these things, we think about cost, we think about effectiveness, we think of what happens with some of those agents. How do we dispose of them? Like the poison gas. That poison gas is still poison gas. You have to find a reliable way to get rid of it. I mean, so there's every system is different. And so these are a lot of things that, depending on what your role is in healthcare, you might have to take into account. Understand, and a lot of it, the reason I'm presenting it to you this way, a lot of you are going to be responsible for documentation. Your worst nightmare for everybody who's in a clinical setting, I've said it before, is you're going to be walking in and all of a sudden you're going to see unannounced in come the inspector. Whether they're from the state, whether they're from the Fed, whether they're from Medicaid, whether they're from Medicare, it doesn't matter. They don't require an invitation to come in. Normally you get a heads up. When do you see them is when there's a problem. When somebody filed a complaint. And then a lot of times they start showing up at 3 o'clock in the morning. And you're walking in the door to start your shift at 7, at 6:30 you get reported. It's like, somebody goes, they said, or blank me. And you have to be on your game. because they're gonna start looking at documentation. They're gonna because they're gonna go to someone who's the quote nurse in charge, saying, okay, I need to see this document, this document, this document, how you disposed of this. And you have to have all, whatever cliche you want to use, your ducks in a row. And you do. This is your job. So there's a lot. The trouble is when you're in, for many of you, RNs with BSNs, and that's what I'm speaking to mostly, or people at a high level of healthcare. Basically, you're responsible for this. You do a little less patient care and a whole lot more documentation and organization than you want to. It's just the nature of the beast. I'm sorry. So understand that. One thing, hey, I learned a whole lot of this from my ex, RN, BSN. Boy, she knew where stuff was. It was nothing if not very good. Something she learned early on that served her well, because you want somebody on that when you're walking around with these people. They can, trust me, they can pull any chart they want, okay, and look at it. If it's not, if there's a problem with it, you're gonna get called. They can look at any red bag thing, they can look at a sharps container. I talked about this with people in my lab. And if it's not all sharps, if some idiot, okay, threw a paper towel or a gauze pad in there around their sharp, you get fined. It's the kind of stuff you gotta be on top of and not be afraid to tell people and say, hey, don't do that. That's your job. They may not like you. They don't have to like you. They have to respect you. They have to follow you. So there's a certain fine line between you. You'll learn how to be supervisor in the appropriate role. Part of your job is going to be learning. They'll teach you about this to manage people. You got to do that. Okay. You're going to learn about Stein's two-word definition of leadership. It's very simple. Follow me. Okay. You show them how to go about doing things. If you do it, they'll do it. Works. My one-word definition of nursing: caring. So you know me, I'm KISS. Keep it simple, stupid. Okay. Permanent termination of the organism's vital bus. You're dead. Therefore, microbes. We don't know if it's dead. Let's see. We're going to do an EEG on the microbe. Can't do that. They don't have a brain. Okay. All of that done. So the accepted definition is they can no longer they can't make more of those bad guys, so we don't have to worry about them. Okay. And it's not instantaneous. One of the things I didn't show you about was the growth curve. Basically, there's a death curve. And how we determine scientifically has to do with the death curve, which is sort of the opposite of the growth curve. It's very exponential. So it's a logarithmic curve, okay? And cells that are active, great thing is they're so busy reproducing, they're very easy to kill. When you start getting to endospores that are in a dormant stage, they're very, very difficult to kill. So we basically have figured out where it would be statistically impossible to do this. And they show you the curve that's involved with it. So what takes longer, the worse it is, the dirtier it is. That's why you're going to see when in an operating room, the first thing we do, and we're going to have instruments that we have to use over and over again, and this is what my ex trained my staff to do, is they put on their gloves and they had their masks and they're all gowned up and they're sitting there putting them into a big bowl of something in our, basically our prep area and cleaning. They're basically getting all that yuck off of them, because that yuck, all that organic stuff is very hard to penetrate. You've got to do it. It's I don't know. We do it at our house with the dishes. We wash the dishes before they go into the dishwasher. I don't rely, if you got stuff that sticks on them, have you ever gone to a restaurant and had a fork that had stuff on it? Okay. And you want to say, I need a new fork. I have a great way of doing it. Amazing how fast that happens. The last thing they want is, who's that idiot holding up the fork? So a whole lot of things, and temperature and pH are the ones we play with. So we're going to look at different things that influence it. We're going to look at ultraviolet. I don't think it's a big deal. Okay, we don't use it because we do have a limited use for it in the food industry, with which I am familiar. Okay, how does it kill or inhibit? To me, it's not a big deal. I'm not going to ask you about, did it do the cell wall? Did it do the membrane? Do the ribosomes? The big problem for me is this: organic matter, saliva, blood, poo-poo can inhibit the actions of disinfectants. So you don't know what's contaminating it, clean it the F off. That's what you're going to do, or you're going to tell people to do. You're going to show them how to do that. You will. So some agents are very least selective. They tend to be effective against the widest range, heat and radiation. They're going to clobber everything. Selective agents are very, very limited. That's when we're going to talk about antimicrobial medications and things like that. The big four targets: cell wall, membrane, the genetic material, DNA and RNA, and proteins. That means ribosomes. The big player for me, cell wall, membrane. I think we're starting to get down here. Proteins are impacted. A lot of ones impact proteins and denatured, and that's good. So in the interest of time, I'm going to stop it here. And then we're going to get into, I want to show you, everybody, what we get into. We're going to start talking about moist heat. And that means the autoclave. And that's the method we use the most. Thank you.